solution, but I think the biggest problem is if you're putting your appliances in your mouth. Like, refrigerators belong in the kitchen, not in your mouth. Welcome to Primary Care Article Recap for January 2025.
I'm Dr. Paul Dillon.
I'm Dr. Simon Moore. In this month's edition, what are we going to cover?
So we're going to start off with your top article on white lesions of the oral cavity.
You got it. And after that, there's going to be cervical polyps. Do we refer or can we manage those in primary care?
And then we're going to talk about a 180-degree shift in treatment of mastitis.
And let's wrap up with sodium intake. Do we restrict that in CHF?
So let's dive right in. So this is what you thought was your top article, and it's only January 2025, but you're calling this as your top article in the Canadian Family Practice Journal. Tell me a little bit about this one.
That's right. So this article is called Common White Lesions of the Oral Cavity. It's written by a dentist who's also a medical student, as well as an oral maxillofacial surgeon, an ENT. Like, we got an all-star team to teach us about all those enigmatic spots on the tongue.
So what are the ones that you worry about? What are some of the features maybe? Or let's start off by talking about your examination.
Yeah, so you're looking at the mouth. You're going to do the whole head and neck exam, check for lymphadenopathy. And it's interesting how specific it is with regards to where the lesions are inside the oral cavity.
So let's start off on the tongue. You've got some white stuff on there. What do you do? What's an examination thing you could do?
Tongue depressor, does it scrape off? Yes or no? And interestingly, we get a lot of these folks come into my urgent care clinic. And at the end of the day, it's actually not candidiasis.
So what else could it be? So now, say they actually talk about gauze instead of the tongue depressor in this one. But say it doesn't come off. What else are you worried about? What are you thinking about?
Yeah, probably the most common is going to be oral hairy leukoplakia. That's the keratin overgrowth. People are really stressed by this. They haven't seen it before, and yet they think that it's yeast, and the yeast treatments obviously aren't going to work.
So you mentioned yeast. We should probably briefly touch on what treatment options there are. So general big picture, you're going to treat for 2 weeks. You can give them fluconazole, 200 milligrams, and then 100 milligrams for the rest of the duration of those 2 weeks. Or you can do oral washes as well.
Yeah, and some of these folks are going to have resistance. If you're convinced that's the diagnosis, we don't swab and recheck. What we do is we just extend the treatment all the way up to 4 weeks.
4 weeks. And an important thing to remember is, why are they getting this? So the article talks about immunosuppression. It doesn't talk specifically about a recommendation to test for HIV potentially, but things to consider is like, why is this happening to this patient right now?
You got it. So I think that we can wrap up with that. Check for dentures and make sure that you soak your dentures or appliances in an antifungal solution. But I think the biggest problem is if you're putting your appliances in your mouth. Like, refrigerators belong in the kitchen, not in your mouth.
Yeah, if there's white growth on stuff in your fridge, you've also got a problem.
There you have it. So let's move on to another diagnosis. Which one do you want to cover?
We talked about oral hairy leukoplakia, oral lichen planus.
Yeah, lichen planus. So this one is going to have a much more reticular and lacy pattern, and it's not on the tongue.
Yeah, and then the other one, frictional keratosis. This was one that was a little bit interesting to me.
Yeah, these two are really easy to get confused because they both occur on the buccal surface, but it's actually really easy to tell them apart.
How are you going to do that?
So the frictional keratosis, that one is going to be your linea alba. You know, we've got these Latin terms so that we sound really smart when we say the name of them. The other term for this one is, what do they call it? Masticatory.
Oh, this is a lovely word. This was
Moriscatiobacarum.
Moriscatobucarum.
Yeah.
You got to say it with your hands. Son.
Say they chew their cheek. Like, honestly, why are you putting it in Latin? So if you look at it, it's a white line, linea alba, maybe chewing their cheek, Moriscatiobacarum. Or if it's lacy, reticulated, you're looking at those Wickham striae. Then you know it's probably not the frictional keratosis. What are we looking at?
Lichen planus.
You got it. Now, of course, we always have to be super on guard for, is this a tongue wart or a tongue cancer? So how do we tell those apart?
So you're going to be looking for more possibly like pedunculated lesions. You're going to want to get a good history from these patients as well.
Yeah, and some of these are going to be condylomatous, and they're going to be heaped up and bulky, or the ones that are necrotic or fungating or friable.
It comes back to what we talked about at the beginning about in your history, if you're going to refer them, you're going to want to get your fingers, your hands on with gloves and really get a feel of the lesion. Is there an underlying mass? And you're going to include that in your note to a specialist for those pre-malignant or malignant lesions.
And I think it's a really great protocol because a lot of times we look at these lesions, we say, oh, I don't know what this is. Like, go see your dentist. They say, my dentist sent me here. But don't just look at it. Don't just scrape it. Don't just gauze it. Get your finger on the lesion, and sometimes it's going to give you a really good idea what's going on.
Yeah, you're going to want to examine not only the lesion, but the entire inside of the mouth. So what are some of those higher risk factors? You've done your examination. What are those things that are going to make you concerned?
Yeah, we're going to lean towards biopsy, especially if it's got those visual appearances we talked about, or if, say, they're a smoker, elderly, heavy alcohol use. What else?
You've got to talk about these. Some patients will use some of those tobacco or chewing tobacco, or betel nut actually showed up in this article as well.
Yeah, that's right. Betel nut is one way they refer to it. Betel quid, and somewhere in Southeast Asia, a lot of these leaves are more common. It's got a stimulant as well as narcotic effect.
Oh.
And those can lead to malignancy. And high-risk sites are going to be...
Tongue, they say, is the highest risk.
But they got all of the
everywhere.
Parts of the mouth. The entire oral lesion.
It'd be easier. A shorter list would be places where you're not as worried. But I think, bottom line, if you're seeing it, I think they specifically mentioned over 200 square millimeters in size. Then you start to get worried.
You got it. All right, so at the end of the day...
Have you ever measured something in the mouth with that? That's got to be an awkward...
Can't say that I've had.
Yeah.
No, I'll guesstimate that, but at the end of the day, if you're worried, you're going to biopsy.
Yeah. Absolutely. Beautiful primary care algorithm for investigation in the article as well. Bottom line, all the arrows, referral for biopsy.
Yeah, exactly. If you know what it is or you don't, still refer for biopsy.
So why don't we move on to a change? So this is something, you know what, a year ago we would have advised totally the opposite, mastitis. So what were you doing? What were we both recommending last year?
Yeah, so, I mean, this is what we were taught in medical school. You've got mastitis. Your patient's got fever. They got a red mass on their breast. Came on suddenly. It's warm. It looks like an infection. Infections you give?
Antibiotics.
Turns out we are totally moving away from that. In fact, even the non-pharmacologic approach to this has totally shifted.
We've flipped it on its head. So we used to say heat application, breast massage, and frequent complete emptying. And now we've changed. So let's look at what are the opposites to those.
Yeah, it makes perfect sense. If you think of the mastitis as inflammation, how do we reverse inflammation?
Yeah, and I think that's what you got to remember is reversing inflammation. So non-steroidal anti-inflammatories, breast rest, and then the last thing was ice application.
Literally the opposite of heat or inflammation.
Boom.
So
there
really
you have
straightforward.
It. Breast rest, ice, and anti-inflammatory.
You got it. And so that's an American Family Physician. It's a recap in January 2025, referencing their own article from August 2024. But it's such an important primary care issue that I totally think it's worth re-mentioning.
Absolutely. What's next? Let's come back to cervical polyps. Is this something that we need to be doing in primary care?
Yeah, so have you ever taken out a cervical polyp in your clinic?
No.
I have not either. I remember in medical school watching an OB-gynecologist do the procedure.
Yeah.
And he said family doctors should be doing this. And I still haven't done it yet.
So you didn't listen to your preceptors? Is that the message?
I graduated, and so now I...
You are that preceptor.
I am,
so I read this article, and you know what? It's one of those things now I'm confident after reading this article and watching a YouTube video with you about it to do it myself. But there's some key points about when to do it and when not to do it.
Yeah, so first of all, we confirm the diagnosis. It's a cervical polyp. It's near the cervix. There is a possible differential we need to think about, which is an endometrial polyp, which is protruded through, but you're going to know that if it's broad-based, if it's not coming off easily with the removal. So they say just go ahead and do it. Do you need anesthesia for this?
So we've undertreated pain in female patients for ages. So what would you give?
So for years we said, oh, we don't need anesthesia for this. It's very interesting. In the article itself, it says that anesthesia is actually not required if you're only grasping the polyp itself with ring forceps.
Yeah, so, I mean, you're going to have these patients for a little while. I would consider giving an anti-inflammatory. You could consider topical as well. But in the video we watched, it was pretty impressive and quick. So you've got a single cervical polyp. You can go in with the ring forceps. You'll note it on diagnosis when you're in there with your speculum that you've lubricated. And you literally go in, ring forceps, pinch, twist, and it'll come off. Bleeding, they say, is pretty minimal as well.
You got it. And if there is bleeding, good point, silver nitrate sticks are good enough for cautery. Anything beyond that, if it's broad-based, if it's very large, if you think it's coming from the os, inside the os, or if it's just not coming off with twisting, that's when you stop and refer.
Yeah, I think really good chance for informed consent with your patients. The article mentions it a few times about the lengthy delay if you're referring for gynecology to take care of this. When you can do it yourself, take it out, send it for histology. Patient's happy, you're happy, gynecologist happy.
You got it. Now, last question. What if we are doing an exam, we see that cervical polyp, the patient has no symptoms?
So this, no symptoms. And then what about a history? Do they still have bleeding after intercourse potentially?
Yeah, so none of that, no symptoms at all.
So you got to talk to the patients and say, we can either watch and wait or we can take it off.
You got it.
So next one, sodium restrictions in heart failure. You mentioned this right at the beginning of this podcast. What is the evidence now on this one? Because this used to be mantra.
Yeah.
We're going to cut salt out.
This is from CFP Journal, Tools for Practice. Love this organization. They're constantly making articles without any pharma input. They ask a clinical question. They do an evidence review. So what do they find?
So salt, I don't know if the salt lobby was in on this one.
Big iodine.
Which is true. That's come up in the news now. People aren't getting enough salt because we've been saying restrict yourselves with salt, and people go for Himalayan salt, which doesn't have iodine in it. So maybe we're going to see.
They're not getting enough
flavors.
iodine.
Exactly.
Amazing.
So
Okay.
maybe we should be listening to Big Salt.
You got it. So what they did, they looked at 4 different systematic reviews. So that was anywhere between 5 to 17 RCTs and up to 1,600 participants. And turns out, yet again, what we learned in med school is wrong.
So I used to say, and I would still say up until reading this article, we need to cut down on salt, or I'd order that low salt diet in the hospital. And some of my patients were really good in terms of their salt restriction. But what did the study show? And this I thought was interesting. Salt restricting only just increased their thirst without any clinical benefit.
You got it. Yeah. So we used to say in med school 2 grams, and now that we've got better evidence, it says we should change that and go up to 2 to 3 grams of salt a day is okay. So not as restrictive as it used to be.
Yeah. So that's another practice changer. And now, what about this one? Now, this one we've heard, it came out of Europe, I think initially, was antibiotics for appendicitis. And the evidence has now improved. And you know what? We want to leave no stone unturned in this one. What's the one stone we have to be worried about in appendicitis?
Yeah, it's the appendicolith.
Yeah,
If
well
there's a
done.
stone in your appendix, if your child's got appendicitis, they need an appendectomy. But what if they don't? So this interesting article from American Family Physician, January 2025. What do they find?
So they found, you know what? You can give antibiotics. Now, there's risks, comes back to informed consent with your patients. So a certain percentage, I believe it was around 20%, are still going to need to get that appendix out. But there's potentially a role for appendicitis to be treated with antibiotics.
You got it. Yeah. And they find that in the next 48 hours, that's usually when we know if the antibiotics are going to work or not. And then they didn't work, they need to go to the operating room. That happens about 20% of the time.
20%. So I look at this from the rural context where I work. If there's going to be any sort of delay potentially to get to a general surgeon, if you have to transport your patients, I still think we want to get them watched by Gen Surg, but potentially start the antibiotics right away.
You got it. And this evidence is solid. It's a 2023 systematic review. They had 13 observational studies plus 4 RCTs to help make this decision. So at the end of the day, talk to the parents, talk to the patient, and find out what they want.
And if they're stoned, they get surgery.
There you go. So if you see that appendicolith.
See, in practice, you were way better at saying that.
Appendicolith.
Appendicolith.
So I guess at the end of the day, if there's a stone, we got to get that stone out.
Yeah, there you go.
Well, that is it for Primary Care Article Recap for January 2025. I'm Dr. Simon Moore.
I'm Dr. Paul Dillon. We'll see you again next month.
If you want more of these, please like, follow, subscribe. You know the drill. See you then.